All right, so objectives for us. We're going to talk about, we're going to kind of take a broad overview of rheumatoid arthritis here. I want to talk a little bit about the pathology, but not delve too deeply into that. We're going to talk quite a bit about the, okay, good, you can hear me, thank you. We're going to talk quite a bit about the clinical presentation, what kind of thing you want to do on a physical exam. We'll talk about some things that mimic RA. We'll talk a little bit about x-rays and some of the notable things that you can see. We'll spend a very brief time on extra-articular manifestations because I think you should be aware of them. But honestly, we're so good at treating rheumatoid arthritis now, we don't see a lot of extra-articular manifestations anymore. And we'll talk through a very basic treatment strategy approach, but there's lots of different places you could take this. And then there's a few specific scenarios that apply to internal medicine residency, certain types of people you might see in clinic or in the hospital that I want to talk to you about specifically. Okay, so rheumatoid arthritis occurs in about 1 in 100 people, so it's a pretty common autoimmune disease. It's slightly female predominant, but not, amazingly so the way we see in lupus. Certainly, I have many male patients with rheumatoid arthritis. Median age of onset for women is 40s to 60s, although you see it as young as little kids and as old as elderly individuals. Men tend to be slightly older, but honestly, I wouldn't dwell too much on this age range. It can really present just about any time in life. So pathology-wise, right, there is a genetic susceptibility that's important. It's been estimated that this maybe accounts for somewhere about 60% of overall susceptibility in individuals. A lot of this is based on your HLA, certain HLA subtypes that might set you up to be more likely to develop an autoimmune process. And there's this overall kind of, that we're not going to delve too deeply into this, but this concept of the shared epitope, meaning that there are, there's epitope spreading, meaning that a pathologic thing you're exposed to, say a bacteria or something like that, that your body recognizes as foreign, starts attacking. There'll be some mistaken identity where then the body will start then attacking your own tissue and your own cells that look similar to that, to your immune system. Right? And as you know from going through medical school and all that, there's a lot of backup mechanisms within the immune system to try to prevent this from happening. But even so, we do still see this occur sometimes. So there's quite a bit of environmental factors that play a role in most individuals. Smoking is a huge driver of autoimmune disease, particularly in RA. And part of that is because of the microbiome that's present in the lungs in this process of citrullination. So and the mouth is a nice example. We know this kind of mechanism has been pretty well described. So the P. gingivalis, right, is one of the bacteria in the mouth that can be present as a sort of pathologically within the microbiome of the mouth and can lead to gingivitis. P. gingivalis produces an enzyme called peptidylarginine deaminase, which can citrullinate different peptides. So that's basically you're adding these citrulline groups onto the end chain of these proteins. Normally the bacteria does that as part of its normal process of living and growing, but it can citrullinate human proteins as well. So your antigen presenting cells will uptake these bacterial particles that are citrulinated because they recognize them as foreign. But then throughout that process, they can start uptaking your own self antigens that have then been citrulinated, processed by the antigen presenting cell. For certain susceptible individuals, that stimulation is enough to activate your T cells, which then activate the B cells and lead to production of CCP antibodies, ACPAs. ACPAs for short, as like the more general term for all the different anti-citrullinated peptide antibodies. So this is a process that we know can occur. And once you make these antibodies, you can start getting inflammation. These antibodies will start causing inflammation in the joints where you have similar peptides with citrulline involved in them. So that can be kind of a building on itself process, right? And certainly we do think similar thing happens in the lungs. In smokers, there's high levels of PAD enzyme present in the lungs. So this kind of process is happening there as well. And changes in the gut microbiome and changes that causes in the innate immune system also might set you up to have some of these processes occur. So that's kind of like a very basic level of this type of process. And you know, in every individual, it's a little bit different. We do also know that in certain people, they might inherit a particular genetic susceptibility, but then they're fine until they develop certain viruses. In adults, Epstein-Barr virus and parvovirus are two ones that are particularly famous for causing this really intense joint inflammation. And they also tend to cause kind of prolonged infections when they occur in adults. And what that does is give you this kind of semi-chronic immune stimulation, which combined with the right inflammatory or the right genetic susceptibility could set you up to have that be sort of the straw that broke the camel's back kind of thing as far as the developing a true autoimmune disease that goes on well after the virus has gone away. We see this in hepatitis as well. Idea here, conceptually, is there's multiple potential triggers, multiple potential genetic differences that could add up and lead to a similar pathologic result of inflammation in the joints in the end, right? So how do these people show up, right? So they, the most typical presentation of rheumatoid arthritis is something you're probably fairly familiar with. Relatively symmetric, mostly small joint predominant, swelling and pain, but the pain in particular tends to be a stiffness that's present upon awakening and is better with activity, right? So you'll have folks who describe, well, my hands hurt so much they wake me up in the night, or when I get up in the morning, they're very painful, they feel tight, I have to take a hot shower, I have to do a lot to get them moving, and it's gonna take them 30 minutes to hours to get loose and moving in the morning. Generally, by the end of their day, as they're doing more, as they're typing all day and work, they actually feel better. It's possible that if they're doing something really aggravating, yeah, that could cause a little discomfort, but the pattern you're looking for is worsening with rest, needing to stretch them out, getting them moving a lot, better with activity, and the swelling being present too. So people telling you they can't get the rings on and off, those are some of the warning signs you are looking for there. There are a portion of patients that have a little bit more unusual presentations. There's a phenomenon called palindromic rheumatism. This will tend to occur in fewer joints, and it has this really intensely inflammatory pattern where if you saw them during the days when it's active, you would say, oh, that really looks like rheumatoid arthritis. But then it kind of goes away and has a lull for even a few weeks before popping back up. That's called palindromic rheumatism. About half of those folks will go on to develop full-blown rheumatoid arthritis. Depending on how bad it is, depends on how you treat it, either NSAIDs. Sometimes if folks are having frequent flares, we'll put them on hydroxychloroquine or something like that. But really monitoring, and some people over time will have even fewer and fewer flares, and then it kind of disappears. Elderly patients will tend to have larger joint symptoms, complaints that might sound more like muscular weakness that are really caused by the joints, right? So someone might be described like, I'm very weak in my hips, and when you really press them about it, it's more that there's a lot of discomfort and stiffness through hips and shoulders. And that can mimic PMR, so getting the antibodies to really pin down what it is is important. There's also a tendency for elderly folks to get more diffuse swelling. So instead of, say, like swelling in a toe joint or an ankle, they might give you more a story, and they might look on exam more like pitting edema generally. Arthritis robustus, not super common. Those are these older folks who will get this really intense synovitis, and you look at them and it looks kind of very impressive, but it's really not very painful. I had a patient or two at the VA like that for sure, but not super common. And then rheumatoid nodulosis, where maybe the joints are less of a problem, but they have a lot of subcutaneous nodules, potentially even bone cysts or nodules in other places outside of the soft tissue. So diagnostic criteria, we have the 2010 ACR and EULAR criteria for RA. Now, this is by no means something you should be memorizing or anything like that, right? This is to get people into clinical trials and that kind of thing. But I put it up to kind of demonstrate the types of things that give you different weightedness for like how much does that possibly represent RA. So if you look at the joint involvement, if there's fewer joints and larger joints, it's a little less likely that that's a rheumatoid presentation, right? If you had 10 large joints, basically every large joint in your body involved, and you had an inflammatory pattern of joint pain there, that's still only 1 point towards diagnosis. As compared to if you had 10 small joints involved, right, that's more strongly suggestive, or even just 4 small joints as compared to 10 large joints, right? So it does tend to be small joint predominant, although you certainly can have large joints involved. The other factor here, of course, we look at rheumatoid factors and ACPAs. This will primarily be your CCP antibodies here, right? When they're 2 times the upper limit of normal, we consider it more highly positive, and that's more suggestive. In particular, a low titer rheumatoid factor is not a definite association with RA. You can have an abnormal inflammatory markers, but as you see, not much weight placed on that. And really, before we officially call somebody rheumatoid, we like to see it present for 6 weeks or longer to understand that it's chronic, as opposed to related to a viral infection or more of a palindromic phenomenon, right? So again, you don't have to memorize all these things. The point being, small joints are important, highly positive, serologies are positive, are helpful. But again, you can also see that if you have enough small joints involved and it's been there for long enough, potentially you can have seronegative disease and still meet criteria. That's another important factor. So briefly, let's touch on some mimics of rheumatoid arthritis, some other things where people are going to show up with inflammatory pattern joint pain. There's tons of things that could look like RA on physical exam by history as well. Certain types of spondyloarthritis will have more smaller joints involved, more peripheral joints and not just back. Psoriatic arthritis in particular can look for all the world like rheumatoid arthritis on physical exam. So keeping these in your mind are important. Most spondyloarthritis patients will describe an inflammatory pattern of back pain, and rheumatoid arthritis does not cause back pain generally. So that's something that should, if presence of back pain and presence of DIP involvement, which is common in psoriatic arthritis but doesn't occur in RA, those are signs from a symptom perspective that you should be kind of exploring elsewhere. Osteoarthritis in the hands. People will tell you they are swollen, but if you press on them, you will feel it's more bony than like a squishy synovium. But they certainly, if you have enough osteoarthritis in your hands, that certainly could give you a pattern of feeling stiff in the morning. So that's something that you potentially will need x-rays or that to help you diagnose. Gout and pseudo-gout can cause joint inflammation for sure. It's actually relatively common for gout to present in the fingers, right? Uric acid will precipitate out of solution at cooler areas of the body, which is why gout will occur more often in feet and also in hands. And pseudo-gout loves the wrist. So those very much can mimic RA, and you'd want to be looking out for the pattern. The chronicity of it will help steer you either towards gout if it's an acute and then resolves, versus RA, which is going to be more persistent over time, right? So you should be suspicious of something else besides RA. If the pattern of joint pain is asymmetric, if it's migratory. So RA is not perfectly symmetric, right? Like if you have this and this MCP, it's not that you necessarily have the same exact ones on both sides. But if you had MCP involvement and PIP involvement on one side, you'd kind of expect roughly the same on the other side. When I say asymmetric, I mean more like there's one DIP here, and then on the right side it's the wrist, and on the left side a knee. So it's kind of patchier and more asymmetric. If it's migrating around, that should make you think of some other etiologies as well. It could be very early rheumatoid arthritis, palindromic rheumatism. There'll tend to be some migratory symptoms, but you need to think of things like gonococcal arthritis, Lyme arthritis, those other things as well. If it's predominantly large joints, it's not impossible that it'd be RA, but you want to make sure you're thinking of the spondyloarthritis, reactive arthritis, those types of things as well. If they're not stiff in the morning, that's probably not RA. Right? That morning stiffness is a very predominant feature. If they, as I mentioned, if they have DIP and back involvement, that's very unlikely to be RA. Rheumatoid factor or CCP negative, it's not impossible. We'll talk about this more. There are a portion of patients who are seronegative, but you know, whenever we have a patient like that, we're always kind of keeping in our mind, like, oh, are they going to develop psoriasis someday or something like that? So you want to keep an open mind. If you see leukopenia or hypocomplementemia, those are things more typically associated with lupus and things in that kind of family of disorders, right? Like lupus, Sjogren's, the myositis, and things like that. Usually, if anything, RA will drive up your white blood cell count and potentially drive up your complements as general markers of inflammation as well. The other situation that comes off relatively often in clinic is somebody was given a diagnosis of seronegative RA years ago, and they got put on all these biologics and nothing ever helped them. And then they're coming to me and just kind of with chronic pain, we get their x-rays and their x-rays are pristine. Well, if their disease was truly uncontrolled and it truly was RA, it should cause damage that's detectable by radiograph. So if you have someone with chronic joint pain that has not been controlled by whatever medicine they're on, and their x-rays are normal, it's probably not RA. So on physical exam, right, the main thing we're looking for is synovitis. So you can see these PIP joints of this gentleman, right, are clearly quite swollen. So you can see it like this fusiform swelling, right, where it bows out like this. But I also want you to notice how he has on this fourth PIP joint some nice wrinkles. The skin right there looks like it'd be a little loose. But on here, the wrinkles are very much puffed out as well. So like one of the first things I'll do is just hold someone's hand like this with their fingers straight and just look at each of the joints compared to the next one, just to kind of, is there one that looks a little different? And then you're squeezing on the sides and kind of on the top, right? With both hands, usually with your two thumbs, squeezing along those joints. And if you squeeze this, you would feel a give to it, a squishiness to it. The other thing I want you to notice is how nice and skinny and wrinkly the DIP joints look here. Those look good. From the angle of this picture, it's really hard to tell if anything's going on in the MCP joints though. Now, there's some famous deformities that RA can cause that honestly we don't see very much anymore unless a patient has had RA since like the 80s or 90s, because we with good treatment, with adequate treatment, these deformities don't develop. Does anybody know what this is called? I don't know if your setups make it easy for you to answer questions or not. This one here, this is called a boutonniere's deformity. So the PIP is flexed and the DIP is hyperextended. This is the more famous that you probably have heard of, a swan neck deformity, in which the DIP is flexed and the PIP is hyperextended. So what happens here is that chronic inflammation in these joints interferes and damages some of the tendinous and ligamentous structures around the joints. So basically in a boutonniere's deformity, the tendons that normally would be aligned right over the top of the digit, they slip off down to the side. So instead of having a string that is running all along this path like this, the string is pulling this way too hard and it's dropped off to the side of this joint and is pulling this way. And this can lead to, when this first starts occurring, the tendon will slip back and forth and the deformity is reducible. Like you could take that person's finger and straighten it out. But you know that it's a tendon, it's under tension. If it stays like this for long enough, you'll get a contracture like that, and that's really functionally impairing, right? You can imagine that this finger, it doesn't flex and bend normally. It's difficult to deal with, right? Same goes for a swan neck. It's the same process, except it's slipping. The tendon that normally would be along the top is slipping off the side up here, so it's pulled this way. And it's up too high here. Here's a lucky person with both at the same time, right? A nice picture of a swan neck and a boutonniere right next to each other. So you might see that show up on an exam, and certainly you want to be aware of it if you see it on a physical exam, that is a sign of a particularly inflammatory type of arthritis, right? Just plain old wear and tear osteoarthritis will not cause this kind of damage. This is ulnar deviation. So as you can see, all the digits are pulled towards the ulnar side. Part of why this happens, again, it's all about ligaments and tendons and alignment. You see how prominent the head of the MCP bones are? So what's happened here is that the proximal phalanx here has actually slipped and subluxed underneath the head of the metacarpal bone. And when that happens, there's kind of nothing keeping it straight in alignment. And then again, the tendons start pulling towards the, pulling tighter, and they get contracted in an ulnar deviated position. But the first thing that happens is that the phalanx here subluxes underneath the head of the metacarpal, and that, if you can imagine where this person's ligaments on the back of their hand are, right? This ligament no longer, or I'm sorry, not ligament, the tendon, this tendon no longer goes up and over this bone. It's because of the inflammation in this joint has damaged it and allowed it to slip to the side. So now this ligament runs, or this tendon runs here, right? And pulls the bone, pulls the whole finger off to the side like that. It's kind of like all of these deformities really have to do with it's almost like your rope is off of the pulley track and the kind of subsequent damage that happens from that. So we all know swan neck and boutonniere. Same things can happen in your toes. So that's a picture of some of these: claw toe, mallet toe, hammer toe. Lots of fun stuff. This can be massively debilitating for patients with rheumatoid arthritis because there's not that much that really helps it. Prevention is really what we're after for it. I mean, they need to wear special shoes with these, with feet that are like this. Functionally, it impairs how they walk. There are certain surgeries that can be done to try to straighten it out, but the outcomes really aren't great. Same with the hands. There's surgeries that can be done for something that is just unworkable, but it's not like getting a knee replacement where you're back to being your old self afterwards. These really are huge problems when they happen. So let's talk about x-rays a bit. X-rays are really important in rheumatoid arthritis for confirming your diagnosis and for monitoring how people are doing. This here is normal hand x-rays, right? So we're gonna come back and reference this. I want you to observe how there's a nice bit of space between the carpal bones, right? Your proximal and your distal row of carpal bones. You can see the cartilage space in between. You can see the distal radial ulnar joint right here, right? A good bit of space there. The ulnar styloid here looks nice and smooth. The surfaces look nice and smooth. And look at the spaces in the MCP joints, PIP joints, and DIP joints, right? How nice and crisp it all looks. All right, we can come back to this when we're looking at others if we need. So these are x-rays of somebody with advanced rheumatoid arthritis. If you like acronyms, which I don't, but here's one if you do like them. Here's some of the abnormalities we can see in radiographs in rheumatoid arthritis. So one of the things we're looking for is alignment. The alignment in these particular films are good, but of course, if someone had chronic ulnar deviation, or if their phalanges were subluxed below their metacarpals, you would be able to see that on an x-ray. So you have to be aware of that. The other A potentially here is lack of ankylosis. Ankylosis means like the fusion of the joint together, which is something you can see in psoriatic arthritis. B for bones, the thing in the bones you see and are notable here, periarticular osteopenia. You see how much thinner those bones look right around the joints from the chronic inflammation. You can appreciate that a little here too. Quite a bit through here. Cartilage space. Cartilage space is often narrow, but as you'll observe, you know, the inflammation is primarily in the synovium, right? So like there's a bit of cartilage space here, but you can see this huge erosion here, right? So one of the things that, the first thing that happens, right, the synovium gets inflamed, and the first spot the synovium will begin to damage and eat into the bone in rheumatoid arthritis is that spot where the synovium attaches directly to the bone, but is not covered by a cartilage. So that's like right here, right? Right here, right? These kind of marginal erosions, right? They're on the edges of the joint space rather than being central erosions. And that's really important to understanding, right? Like it makes sense, right? It's the spot where that synovium can get right at the bone and the bone isn't protected by cartilage. But of course, this is going to thin your cartilage over time. These joints are narrow. We have erosions in most of these joints, probably a big cyst in the bone here. And you can even see down in the wrist here, there's a lot of cysts in this ulnar styloid, in the distal radius. These bones, the carpal bones, have a bit of a moth-eaten look, even though you can still see the cartilage space there. And this wrist really clearly has been pretty eaten up. Very hard to see, very destructive in this wrist, very hard to see cartilage space. Can't even see the distal radial ulnar joint here, and this ulnar styloid has just been eaten up. Okay, any questions about these radiographs? Soft tissue swelling as well. Sometimes you can even, it doesn't project very well in this image, but sometimes, of course, you can even see that their soft tissue is puffed out around these joints. That's not specific for RA, of course, but the presence of these type of erosions, right? This type of thing, pretty slam dunk rheumatoid arthritis. All right, questions. Okay. Let's go back one real quick, just another peek at the normal, just for comparison's sake. So just kind of take a general look at it, right? Very different, right? This is pretty bad RA. My goal when I'm taking care of new RA patients is that they never have anything show up on their x-rays because we're doing a good job of taking care of it, right? So here's some different x-rays, right? So this is a little different. It doesn't look good. It doesn't look normal, right? But really what we have in this one, there's some narrowing of cartilage space for sure, right? These are very tight. These are very tight. You barely see the cartilage there. The DIP joints are very, very tight. It's almost like you can barely see the joint there. And you see these big bony bumps there, right? So this is a picture of osteoarthritis. And you can kind of see how on physical exam, these areas are going to look, they're going to look enlarged. So these are Heberdine's and Bouchard's nodes, right? Which are just these big bony nodules, right? When bone is rubbing on bone, bone is stupid. All it knows how to do is make more bone. So you get these big, chunky osteophytes or bone spurs. You can see a big one right here. Obviously, if you're physically looking at this person, they might tell you this is swollen, but if you feel that, it's going to be bony and hard underneath. Now, someone with this much arthritis certainly is going to feel a bit stiff, but the important things that you don't see are erosions, right, along these high-risk areas, right? Don't see that. Don't see any erosions in here or cysts in here. You might for a second be like, is that an erosion? But it's really just like a little bone spur that's kind of sticking off the edge there more than an actual erosion into the bone. So this is just an example of how helpful your x-rays can be in confirming or leading you off of a diagnosis. So let's talk about general workup. You see a patient, they've got small joint, symmetric arthritis, they're stiff in the morning, you think they probably have RA. So what are you gonna check? So on your labs, you're gonna have probably a normal white blood cell count, potentially a little bit high if it's really inflammatory, but for the most part, your CBC is probably gonna be normal. If they really have a lot of bad chronic inflammation, you might see a little bit of anemia, with a normal MCV, like anemia of chronic disease pattern. Platelets sometimes are elevated as kind of a reactive thrombocytosis, usually only slightly so, but they very well could be normal. CMP, probably normal. Again, maybe you'll see high globulins, maybe you'll see low albumin if things have been really aggressive and inflammatory, but it's probably going to be fine. As we talked about before, not everyone will have elevated inflammatory markers, but you certainly can see elevated inflammatory markers. If they have really high rheumatoid factors, often their SED rate will actually stay elevated due to just like the hyperimmunoglobulinemia. So let's talk about our more specific testing, right? Rheumatoid factor, everyone has heard of a rheumatoid factor. It's positive in about 70 to 80% of patients with RA, which leaves a solid 20 to 30% of people who do not have a rheumatoid factor, who have RA. The specificity here, 86%, that's in people with arthritis that looks like RA. That's not in just any random person you check a rheumatoid factor in, right? Folks with hepatitis C will probably have a rheumatoid factor. Folks with like a chronic infection of any kind could have a rheumatoid factor. Anti-CCP antibodies are seen in about 60 to 70% of folks with RA. But as you can see, a lot more specific. There's not that much that will cause a CCP to be positive, unlike a rheumatoid factor that a lot of different things can make positive. Important other note, an ANA is positive in about 30%, and usually all the subtests that we do, like in lupus, like double-stranded DNA antibodies, Smith antibodies, usually those are all negative. We sometimes see an SSA positive, but just kind of something to know. Just because they have a positive ANA doesn't necessarily mean that it's something else. And then just as a reminder, all a rheumatoid factor is an antibody against the constant region of another antibody, right? So a lot of chronic infectious processes could potentially lead to a situation where you get a rheumatoid factor. So some extra-articular stuff. We don't see a whole lot of this anymore, right? Like rheumatoid arthritis in the lungs or rheumatoid pericarditis. It certainly happens. You'll probably see it happen once or twice through residency, but by no means is it the expectation. Usually this is happening to people who have seropositive disease who are not on medicine, and it takes a long time to develop. So like, for example, I have a gentleman who's got that arthritis robustus picture, right? These big swollen joints, but they don't bother him. A different rheumatologist tried to convince him to start methotrexate, and he was like, I'm not taking that, you know, and because he felt okay, even though this was a relatively inflammatory thing. He wound up developing some neurologic issues and had a meningeal enhancement issues and wound up having a seizure related to it that we think, as best we can prove, is related to his untreated RA. Right? So that's the situation, right? People who've had long-standing, not treated seropositive arthritis are the ones who are really going to get these extra-articular things. So in a very general sense, certainly you can have fevers, weight loss, and fatigue, but you don't necessarily have to have those. Scleritis is probably the most common extra-articular manifestation of RA that I actually see. And sometimes that is aggressive enough that that is really what drives the treatment. Episcleritis can occur as well. Cardiac-wise, you can have pericarditis, myocarditis. You can get a rheumatoid vasculitis that involves the heart, and you can get nodules in the heart tissue itself. Pleuritis and infusions have certainly been described. ILD, COP, and bronchiolitis obliterans have been described as well. Skin nodules are not terribly uncommon, but again, usually super treatable, so we don't see a lot. And you can get a vasculitis that presents with the palpable purpura like other skin vasculitises would. Neurologic entrapment neuropathies, so like carpal tunnel, tarsal tunnel, cubital tunnel, those are all quite common. If you have a rheumatoid vasculitis, you can get a mononeuritis multiplex as well. And occasionally folks get peripheral neuropathy, but not very common. Hematologic Felty syndrome is something you always want to be aware of. And folks with RA do have higher risk of getting lymphoma than the general population. And then, you know, we do see some secondary diseases. Some of these are not really truly extra-articular RA, but we can see Sjogren syndrome, so dry eye, dry mouth kind of pattern. Particularly long-standing untreated RA can lead to amyloidosis. Osteoporosis, somewhat in RA, but a lot of times we are provoking that with steroids. And an important thing, the life expectancy in RA is very similar to the general population, but there's a tendency to get heart disease about 10 years sooner than they would if they did not have this autoimmune condition. So more and more there's more and more research on this, and more we think of heart disease and vascular inflammation as being a big problem in autoimmune conditions, right? So treatment-wise, what do you need to know? As anyone with a TV probably knows, there's a ton of different treatment options for rheumatoid arthritis, right? Every week there's a new commercial out. People have been asking me about the one of the lady taking pictures of the wild horses and all that. Well, I don't know. You guys have all been working through COVID. Maybe you're watching less TV than everybody else. That one's for Rinvoq. So lots of options, which is great. We're in a good situation in that way with RA. So your first line therapy for RA, it's been around forever. We know it works for probably about 40 to 50% of people with RA. It's what they'll need. They won't ever need to move on to anything else. Using once weekly methotrexate. We generally need a dose of 15 to 25 milligrams. And remember, this is once a week. If you get somebody admitted to the hospital or see them in clinic, once weekly, not every day. Toxic if you take it every day, right? Once weekly. So that's your initial treatment for most patients with RA. Our approach is what we call treat to target, which means that you set a goal of low disease activity to remission, and if the patient is not there within 3 months, you switch what you're doing, right? Even if they improved, if you're not to low disease activity or remission within 3 months, you get more aggressive about it. We know that by doing this, that we spare people the long-term consequences, that people have fewer, less radiologic damage, that they have less functional impairment, that they have higher quality of life if we adopt this aggressive treatment strategy. We have enough options out there. You gotta go for it. We move quickly. And sometimes this is intimidating to patients who are just meeting for the first time, that and it feels like we're kind of flailing because we're switching them from one thing to the next so quickly, but we know this is what works, right? So methotrexates are our first option. There's a lot of issues with side effects of methotrexate. It makes people feel tired. It often will make people feel a bit nauseous when they start it. So intolerance is not terribly unusual. If they're intolerant, we can switch them to other agents. Leflunomide is a particularly well-tolerated option, and it's a once a day, pretty easy for folks to take. Sometimes we use hydroxychloroquine, but usually that is not enough for somebody with RA to control their symptoms. If they're mild or early, that might be an option. But say they tolerate your methotrexate well, but after 3 months, they have only had 20% improvement. Could call that an incomplete response, and we step up our game. So there is this option of therapy we call triple therapy here, which is the combination of methotrexate, sulfasalazine, and hydroxychloroquine. In older trials, this combination was found to be similarly effective to starting a TNF inhibitor, but I can tell you for sure, nobody wants to do this, right? The methotrexate already makes a lot of people queasy. The doses of sulfasalazine you need are somewhere between 2 and 3 grams per day, which is about 6 horse pills a day, and people just don't want to do it. Sulfasalazine upsets like everybody's stomach. Plaquenil, as you all probably know, is pretty well tolerated. But doing this is just a lot of pills, right? People don't like doing this. If they're scared to death of biologics or have some contraindication, it might be reasonable, but I rarely will go down that road. Because we have so many wonderful biologics and small molecules at this place. So usually our approach, 3 months of methotrexate, didn't work well enough, we jump right onto a biologic. Your first option is almost always going to be the TNF inhibitors, right? These have sort of been around the longest of our biologics, with about 20 years of data behind them now. Etanercept or Enbrel, adalimumab or Humira, and infliximab or Remicade are 3 of the main ones, but there is several others. It's a different treatment strategy conceptually, right? Methotrexate is a folic acid antagonist. It kind of works by blocking folic acid metabolism in such a way that it lowers the activation of white blood cells without actually decreasing their numbers significantly. So it's a relatively general approach to the immune system, as compared to a biologic where they're taking an injection of something that is going in and blocking one single target while leaving everything else alone, right? And then you benefit from the downstream effect of that target. So the TNF is heavily expressed in joint, tumor necrosis factor alpha in particular, heavily expressed in joint tissue, which is why these kind of came about as a conceptual idea for a target. And they are all a little bit different. So the UMAB on the end of adalimumab means it's a humanized monoclonal antibody. The IMAB on the end of infliximab means it's a mouse antibody. All that really means is that you are more likely to develop antibodies to the medicine itself. Etanercept is a structurally different, it's almost like a false receptor to TNF. So 3 different ways of targeting one single thing. And people do really well on it. Our data suggests that about 70% of folks will achieve our goal of low disease activity or remission on these agents. Now, some people, TNF just isn't an important part of their inflammation process. Perhaps there's something else that has gone wrong in the immunologic pathway to lead to this. So we do have several other options too. Abatacept is a T cell co-stimulation signal blocker. So that's like a strong anti-T cell receptor, like blocks the second signal that's required to activate your T cells. Anti-IL-6, y'all probably are more familiar than these due to COVID than you otherwise would have been, right? Because we use anti-IL-6 to treat like cytokine storm and things like that as well. But they have good data for rheumatoid arthritis. We use these in several autoimmune diseases. They work for a lot of different types of vasculitis as well. And one of the newer groups are the JAK inhibitors. So JAK inhibitors are not technically biologics, as you can tell from the structure of their names. They're these small molecules. What's nice about that is that these are oral medicines. So patients like that. They don't like having to give themselves a shot. These essentially function, though, and work like a biologic agent. Really, they have one intracellular signaling target and are immune suppressing as well. And the other one I didn't put on here is rituximab, which also is approved for RA, and there's a few specific circumstances that we use it for. Now, this is sort of our standard trajectory here, right? But very importantly, methotrexate and leflunomide are significantly teratogenic, right? Methotrexate will cause miscarriages if taken in the early parts of pregnancy. And leflunomide is also damaging to newborn baby. Methotrexate really should be stopped 12 weeks before attempting conception if you have a young lady who's wanting to get pregnant. Leflunomide needs even longer, and actually if someone's been on leflunomide, you have to give them a several-week course of cholestyramine to actually get the leflunomide out of their system because it's so heavily lipid bound. So there are certain circumstances where you're skipping this initial stage altogether and just jumping to safer medicines like etanercept or the biologics, which actually have much better, this group has much better safety in pregnancy. Okay. So I think that the key points for you all to be aware of and know is this treat to target approach. So like understanding that even if you improve, if you don't improve enough within the 3-month period that it takes for the medicine to be at its maximum effectiveness, you switch, right? You don't keep going on an okay path. You go out and you actively are aggressively trying to find what's going to work best for your individual patient. I think it's important to know that methotrexate is first, even though our biologics are more effective, right? There's like a overall cost of these things. Biologics are extremely expensive, and there's been a lot of attempts to make biosimilars and a lot of kind of political industry stuff about why those are and are not available and as effective as we would like them to be, and why they have not been kind of marketed as aggressively, and access to those biosimilars, which essentially are what could be the generic of biologics. It's a lot of, when you try to run healthcare like a capitalist process, which is a conversation for a whole nother day. If you wind up in this sort of situation, right? I don't know if this is still true, but I had read before that adalimumab is the most profitable medicine in the entire world. And I certainly could believe that, considering we use it for so many different things. All right, anyways, questions about treatment? Okay. A little after. Do you guys have to stop now, or do you have time to run very quickly through a few specific scenarios? Thoughts? Okay. I'll go through these quickly because I know you all have work to get back to do, but there's a few specific scenarios that I've seen come up, like on the wards and things like that, that I want you to just kind of be aware of. We could do this one quickly. I don't think this one's as important. So you have a 59-year-old female with hypertension who is obese, who presents from migratory arthralgias. She's been to multiple EDs with swollen knuckles. Her ankle has been swollen enough that she couldn't walk, right? You examine her hands. There is synovitis, so what should be ordered? We talked a little bit about getting the basic stuff, CBC, CMP. You want your RF and CCP, your inflammatory markers. To evaluate further for other types of arthritis, and ANA is potentially useful. HLA-B27, it comes with a lot of baggage, right? I probably wouldn't check it in this situation. But you want to just be thinking of other things that could explain her symptoms as well. If you really think someone has RA, you should be checking their hepatitis B serologies and quantiferon to look for latent tuberculosis, because a lot of the medicines we use can reactivate these two things specifically. I usually do check an HIV test and a hepatitis C test as well, because those are treatable infections and shouldn't we treat them? But the our biologic medicines are a lot less likely to cause reactivation of hep C. And there's certain ones you would kind of shy away from if a patient was HIV positive as well. And I usually will get baseline x-rays of their hands. Ball catcher view is a view where you get like this look where they're doing this with their hands, and it gives you a really nice look in the MCP joints. And that's really the only point I wanted to make there. So more importantly, here, scenario 2, you're on GIM, you're in your clinic block of this, so you're seeing pre-op patients, right? I don't know if y'all still do this, but so you have this 50-year-old gentleman. He's got a history of RA, but he's doing really well. He's on Humira, 40 milligrams every 2 weeks, or adalimumab, and methotrexate, 20 milligrams weekly. He's getting a cholecystectomy, and he presents for pre-op clearance. Let's see. So everything looks good on exam. So what do you want to do? What other tests do you need? Basic labs are reasonable. This has been what to do with these medications is a big area of debate. There's been a lot of studies now, mostly retrospective observational stuff, so not super solid data, although there's a guy up at Hopkins who's really looking at this in a lot more detail. Looking at, you can probably keep the methotrexate, and people don't have, in these retrospective studies, people are not shown to have higher rates of infections. You would probably, there's some debate about how it may or may not impact wound healing. There's some debate about if you're having a bowel surgery or something with higher risk of infection, should you really stop? Our general advice right now is that we hold methotrexate the dose before and after the surgery, and then once everything looks good and there's no post-op infection, you can restart it. But very much debatable, and that is in flux now, and we probably will have better studies coming out all the time on this. Similarly with Humira, right? Like Humira, the way it works, it's so targeted, it doesn't set you up to just catch every little thing, right? So they've looked at this particularly in joint replacement surgeries, which is a common surgery for our folks to get. And there's a lot of debate too that the methotrexates, that they probably don't increase the risk for infections for those types of surgery. Right now, our guidelines still say for the biologic agents, you should stop them 1 dose before the surgery, 1 dose after at least, but you really want to have someone cleared from an infection standpoint before you restart them. So that's where our guidelines stand. We do hold them based on not great data and debatable. If you had somebody who was heavily reliant on their TNF inhibitor, like for example, I have a lady with Takayasu's arteritis who's pretty sick, who is on infliximab. I probably would not hold that for a surgery that had low risk of infection because of how bad her situation from an autoimmune perspective is. But for this gentleman with well-controlled RA, you can probably get away with missing a week or two just to guarantee there's no additional risk of infections. Again, this is something we're seeing more and more studies coming out on that are prospective. My other important point here, what else should you order for this gentleman with chronic rheumatoid arthritis? So before anyone gets surgery with RA, you should get cervical spine films. You may remember I told you before the back is rarely involved with RA. Well, you can get synovitis at the atlantoaxial joints that damage these ligamentous support structures here, which can lead to atlantoaxial instability, right? So here's, right, your atlas, right? Top bone here is kind of a ring shaped, and then your axis goes up in it like this. So this is the dens. You see where I'm outlining the dens here. The dens is held in place to keep it from crushing your spinal cord, right? That goes down this back part here, right? By all these ligaments. If someone has synovitis at the atlantoaxial joint, that can damage these ligaments. And when you order this, you can't just get a regular C-spine film, right? That looks fine. That's a normal cervical spine. You need flexion and extension film. So they get a straight one. Then they do the picture with the patient flexed and extended. And what you're looking for is, does this dens, see here, shift all the way backwards, right? That dens is all the way back there. That can impinge on the spinal cord, which could be disastrous during a surgery. The problem is when they're intubating, right, they tilt back, you do a jaw thrust, right? So not so much when you're going in, but when you're extubating someone and they quickly are moving forward, you can get spinal cord impingement acutely that can leave people paralyzed. So really, you need to know if this is present, and the anesthesiologist needs to know if this is present. This will tend to happen in people with very long-standing RA, but you know, you want to be sure you know what you're talking about. So right, this should only be 3 millimeters, and it should stay the same regardless of your position. This should be greater than 14 millimeters. So this person here has atlantoaxial instability, and their anesthesiologist needs to know about that before their surgery. All right, last scenario. So you have a person, another gentleman with RA, well controlled on methotrexate, sulfasalazine, and hydroxychloroquine, and a bit of prednisone. He comes in with fever, shortness of breath, productive cough times 1 week. RA is under good control. Has no joint pain or morning stiffness. So question number 1 that we usually get when folks with an autoimmune disease come in with something else is, oh, could it be their autoimmune disease? In RA, you'll recall we talked about if people are going to have an extra-articular manifestation of their RA, that's typically going to occur in someone who's poorly controlled, not on meds, right? So unlikely that it's like an ILD presentation of his RA. On your radar, but unlikely. So you get a chest radiograph, shows a focal consolidation consistent with pneumonia. You start him on antibiotics. So what should you do with all of these medicines, right? So when you're dealing with a serious infection, we do hold immune suppressing medicines, right? So the methotrexate should be held. Sulfasalazine is not a strong immune suppressant, but you'd probably hold it in this situation as well. Hydroxychloroquine is not immune suppressing, so you can keep that while treating for infection, right? Immune modulating, not immune suppressing. And the other problem, the prednisone, if they've been on that chronically, even though that is immune suppressing, you wouldn't want to just abruptly stop it because they could be adrenally insufficient. So that's an area where you would get our help with trying to maybe lower the dose down a little bit to allow them to recover. Let's see. And if they were on a TNF inhibitor and they're coming in with a new pneumonia, the other thing you have to remember with TNF inhibitors is tuberculosis. So you would want to get an updated quantiferon or T-spot. Okay? Those are 2 situations I've definitely seen before, and I just want you guys to be aware of. Of course, our consult team is always right around the corner. We're happy to answer any questions you have. But that's the end of my story. Oh, one last question. If you had someone on rituximab, they can get chronically low immunoglobulin levels, so checking their IgG levels and other immunoglobulins as well, but IgG in particular, persistently low IgG is associated with worse infections. If that was low, you would potentially give them a dose of IVIG while they're in the hospital to boost that and help them fight the infection off.